Okay, that was a lot, but we're moving on. So, Perio, chapter 3, okay, of our first periodontal exam. Periodontology exam. I better get this stuff together before we move on. Okay, ready? So I'm going to keep it moving. Now, chapter 3 is loaded. A whole bunch of stars. I do have the marks, so I'll let you know. Wow, look, this is what hygiene does to us. Our hair's just like spread out all crazy and stuff. We're just going to leave that there and tuck it. Okay, let's keep going. All right, so chapter 3, Perio, let's go. Get comfortable, get your study stuff, let's do it. All right, so what is pathogenesis? The sequence of events that occur during a development of a disease or abnormal condition. Well, guess what? There is absolutely no star on this, so pathogenesis, goodbye. It's the sequence of event that occur during the development of disease or abnormal condition. Well, guess what? There's no star. We're moving on. Okay, there's quite a few of these. Okay. What is periodontal disease? Oh my goodness, we're going to know all this stuff, aren't we? Periodontal disease is a bacterial infection of the periodontium. The whole ordeal. It is a disease. It's a bacterial infection of the periodontium. The whole ordeal. And there's two types of periodontal disease, okay? The two types of periodontal disease are gingivitis or periodontitis. So really, periodontal disease is, that covers anything that's inflamed in there. And we only have the periodontium and the gingiva, right? Periodontium includes the gingiva, so that's weird. So anyways, what is periodontal disease? There's a star on here. It's a bacterial infection of the periodontium. And there's two types of periodontal disease, gingivitis or periodontitis. Star. What is gingivitis? Well, we know itis, gingiva, inflammation of the gingiva. This says it is a bacterial infection that is confined to the gingiva, results in reversible destruction of the tissues in the periodontium. A lot of words, sounds very professional, but you know what it is. Gingivitis is reversible. We know it's inflammation of the gingiva, which is a part of the tissue in the periodontium. Okay, we got that. Star, what is periodontitis? It's a bacterial infection. So you feel the trend here, disease, these itises, they're all bacterial infections. Bacteria cause this stuff to happen. Well, it's actually our immune system, right? But they help initiate the process. So it's a periodontitis is a bacterial infection of all of the parts of the periodontium, including the gingiva, the periodontal ligaments, the cementum, and the bone, okay? And this results is irreversible tissue damage. Once the bone, the cementum, the gingiva, and the PDLs are gone, they're infected with periodontitis. I mean, they're inflamed and things are happening. It's irreversible. We know this though. Moving on. What is the difference between periodontal disease and periodontitis? There's a star here. Let's read that again. What is the difference between periodontal disease and periodontitis? Well, we know periodontitis is a part of a periodontal disease, right? We know it is a type of periodontal disease. Let's see. So periodontal disease is a bacterial infection of the periodontium, the whole thing, whereas periodontitis is just inflammation of the periodontium. Okay, so periodontitis and gingivitis are two types of periodontal disease. So periodontal disease is a bacterial infection of the periodontium. Doesn't matter if it's gingivitis or if it's periodontitis, whereas periodontitis is inflammation of the periodontium. Does that make sense? I hope so. Okay, moving on because we got this. There's a lot to cover. Give clinical picture of health in the periodontium. There is a star here. So the clinical picture, so what are we going to see in the healthy periodontium? We're going to see pink, firm, no bleeding. In a healthy periodontium, healthy all of this stuff, the whole ordeal, it's going to be pink, it's going to be firm, and it's not going to bleed, right? Awesome. Give the histological health in a healthy sulcus. So I'm thinking these are like cells. There's a star here. Let's see. Okay, histological. What are we going to see in there in a healthy sulcus? We're going to see the gingival epithelium is coronal to the CEJ, right? It's going to attach above the CEJ in a normal, healthy sulcus. Supragingival fibers are intact, which means those circular gingival fibers are intact, right? They're they're not really above the gingiva. I don't really know. But just know that in a healthy sulcus, the junctional epithelial is coronal to the CEJ. Supragingival fibers are intact. I think that free gingiva is kind of up there. So I think about those circular fibers that support the free gingiva. Those are intact. Supragingival, we'll call that because it's not really down in the sulcus, right? So alveolar bone is intact, right? And then we have the periodontal ligaments are intact. Well, that's awesome. Those are all things that make up the periodontium. So in a healthy sulcus, we're going to see the JE is above the CEJ. We're going to see supragingival fibers intact. So that free gingival margin is going to be your 0.5 millimeters to 2 millimeters tight, you know. We're going to see alveolar bone intact. We're going to see the periodontal ligaments all there, all good, intact. That was a star, so we got this. Keep going. Gingivitis is a type of periodontal disease characterized by changes in the ... blank. So, gingivitis is a type of periodontal disease characterized by changes in the... This is a star. Okay, we got this. Okay. First, I'm going to say, how do you characterize, what are trained eyes trained to see in the gingiva? When they're looking at gingiva, they're looking at the color, the contour, and the consistency, the 3 C's. Gingiva, you want to see 3 C's: the color, the consistency, and the contour. Okay, that's very important because we will be doing gingival descriptions, so know that. The trained eye, we need to know that when we look at gingiva, we want to see the 3 C's. We want to see color, we want to see the consistency, and we want to see the contour. Contour, is it knife-shaped? Consistency, is it firm? Is it semi-firm? Is it spongy? Color, is it pink? Okay, so this is a star. Gingivitis is a type of periodontal disease characterized by changes in the color, contour, and consistency of gingival tissues, right? Because we're looking at the gingiva, and what do we look at? Okay, so the 3 C's. So in gingivitis, we're looking at the color, the contour, and the consistency. It's changes in that, okay? It's characterized by the changes of that, and it's observed clinically from 4 to 14 days. Okay, gingivitis is observed clinically from 4 to 14 days after biofilm accumulation in gingivitis. What's cool is we know that's within 2 weeks. So within 2 weeks, we're going to see the gingivitis is relevant. It is there, evident. The color, consistency, and the contour. You're going to have inflamed, spongy gums, and they're going to look red and angry. They're going to look angry at you. So it's observed clinically in 4 to 14 days. So about 4 to 2 weeks. So 4 to 14 days after biofilm accumulation in the gingival sulcus. Because why is it inflaming? They're getting down in there, and that's your inflammatory response, right? That was a star. Okay, another star. Clinical picture of gingivitis. Kind of the same thing. What are we going to see in gingivitis? We know it's reversible damage. We're going to see red, we're going to see swollen, and bleeding is likely. Okay, 3 signs. We're going to see red. They're red, angry, they're inflamed, they're mad, they're irritated. They are red. They are swollen. They are probably going to bleed. We know that. Anytime you see bleeding, it's evidence of disease. Okay, so they want to see a gingival pocket, histological. So we're probably looking at maybe the JE and this and that. Okay, there's a star here. So in a gingival pocket, not a periodontal pocket, but a gingival pocket, gingivitis, okay? We're talking about gingivitis. So the JE is at the CEJ, okay? Right? So before, in healthy, the junctional epithelium is going to be above the CEJ, right? Let me double check on that. Let me double check. Boom, 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 boom. Okay, yep. So CEJ, the junctional epithelium is coronal to the CEJ in a healthy sulcus, right? So in gingivitis, we're going to have the junctional epithelium at the CEJ. Okay, so it's going to be down a little bit more because it's going to have deeper probing depths, which would be about 4 millimeters, right? So the supragingival fiber destruction. So right here is all inflamed. Your free gingiva is inflamed. So that circular, we'll think about the circular gingival fiber. So your supragingival fiber is destruction. Okay, so it's no longer there holding on because it's inflamed. So it's tore them apart. Just think of that. Okay, your free gingiva is up here, red and angry and swollen. It ripped those. It's destructed. But the alveolar bone is intact. That's why it can be reversible. And the periodontal ligaments are still intact. Okay, they didn't have to resorb. Nothing had to happen to them. Okay, moving on. Acute gingivitis. So there's acute and chronic. There's a star here. Acute gingivitis. It's acute. It's a little, we know what acute means, right? Just a little bit. So it's gingivitis that lasts for a short period of time. It's just a cute little bit of gingivitis. We can clean it and get it better for you. It's acute. It's just a short period of time. It's characterized by fluid in the gingival connective tissues. Okay. And the tissue appears swollen. So acute gingivitis is your inflamed gingivitis. It lasts for just a short period of time because we can fix that. It's reversible. We'll get all that stuff out of there. And it's characterized by fluid in the gingival connective tissues. So it's inflaming. So a lot of those white blood cells and everything, they're reacting. They're getting to the site to try and get that bacteria away. So you're going to have more accumulation of all those white blood cells, and with them comes fluid too, right? Because they're engulfing things and spitting things out, creating extracellular fluid in those connective tissues. So I know that's a lot to take in that fast, because I know I'm talking faster. I'm trying to speed it up, but just know gingivitis, acute gingivitis, is just a short period of time. It's swollen, and it's going to be characterized by the fluid in the gingival connective tissues. All those little cells that were in the connective tissue, all those white blood cells, they're sending fluid and cells up to that inflamed area to try and fight that infection down, or, get the bacteria out of there. Okay, I know that was a lot. I hope you're following. Chronic gingivitis. There's a star here. So chronic gingivitis lasts for months or years. It says it is still reversible. It's gingivitis. It's just going to take some time. It just keeps coming back. Some people are more susceptible to this stuff. It's a lasting gingivitis, chronic. It's a long time, months or years. New collagen fibers are formed, resulting in a more fibrotic tissue, meaning that it's more fiber. It's going to be a little bit rougher and tougher, so it's tougher to get rid of. Just think of that. Fiber is rough and tough, and it's hard to get rid of because it's rough and tough. So new collagen fibers are formed, resulting in a more fibrotic tissue. So chronic gingivitis, the reason why it's lasting so long, it's rough and tough, and it's a little harder to get rid of. It's those collagen fibers that are in the connective tissue. Remember, it's got collagen, it's got fibrotic cells. Fibroblasts are in the ligaments, remember? So I know I'm going really fast, but chronic gingivitis lasts for months or years. New collagen fibers are formed, resulting in a fibrous tissue, fibrotic tissue. More of that, rough and toughness. That's why it lasts longer. It's rough, tough, hard to get rid of. Okay, but it is reversible. Whew, okay, let's do it. We're trucking along. Progression of gingivitis. Star. Okay, there's a lot of stars here. Progression of gingivitis. Okay. So the tissue damage in gingivitis is reversible. The body can repair the damage. We know this. So the progression of gingivitis, we know the tissue damage it's reversible, and the body can repair the damage. And in many cases, gingivitis may persist for years without progressing to periodontitis. Okay, we know this. So the progression of gingivitis, we know it's not always going to become periodontitis. We know that it can go on and on for years without being periodontitis, and we know that it is reversible and the body can repair the damage. That's the progression of gingivitis. It can be repaired, we know that, or it can persist for years and never go into being periodontitis. Okay? Star here. Periodontitis is a type of periodontal disease. We know that. That is characterized by, okay, so what are we going to see in periodontitis? Why is it characterized as periodontitis? We know it's a periodontal disease, but what makes it periodontitis? We're going to see apical migration of the junctional epithelium. That is a big saying that you're going to need to know and embed in your head. Whenever there is periodontitis, periodontal disease, like true periodontitis, you're going to see apical migration of the junctional epithelium. Say that out loud about 5 times to yourself. Apical migration of the junctional epithelium. It's going to be loss of connective tissue, loss of the alveolar bone. Tissue damage of periodontitis is permanent, not reversible. We know that. So all this is receding. It's bad. The bone's going away. Everything's receding. And that connective tissue that was keeping it up and pretty is going away too. Okay, there's not a lot there because there's not many cells left. It's all receding. So apical migration of the junctional epithelium, loss of connective tissue. It's not really connecting to anything anymore. It's, once there's so much gone, it's loose and mobile. Your teeth are, Loss of the bone, we know that. It's irreversible. So, star, a clinical picture of periodontitis. So what are we going to see in periodontitis? Permanent destruction. It's going to be pink or purplish, okay? It's no longer red. It's beyond that. It's pink or purplish. Swollen or fibrotic. It's going to be swollen or tough. And bleeding. Obviously, there's going to be bleeding. Okay, so what are we going to see in a periodontal pocket? Periodontal pocket histological. There's a star here. We're going to see the junctional epithelium down on the cementum, right? Because it's receded. We had coronal to the CEJ was in healthy sulcus, and then we had at the CEJ was with gingivitis, and now we're lower than the CEJ. The junctional epithelium is on the cementum. It is going down, okay? It's on the cementum here. Supragingival fiber destruction. We know that happens in gingivitis, so we know this is all destroyed. Alveolar bone destruction and periodontal ligament destruction. Histological, just know junctional epithelium, supragingival fibers, alveolar bone, and the periodontal ligaments. All that's destroyed, okay? We know this. All right, so there's a star here. Microscopic periodontitis, okay? Microscopically, so what are we going to see in periodontal ligaments? Periodontitis. What are we going to see microscopically in periodontitis? And there's a star here. The junctional epithelium extends ridges into the connective tissue. Okay, so typically, that junctional epithelium, remember, is nice and smooth, right? It doesn't have those big wavy lamina, the basal lamina, right? It doesn't have those big wavy interfaces. So in periodontitis, it is going to have those. So junctional epithelium, now instead of it being nice and smooth and happy, it's going to increase its surface area. It's just really trying to connect to anything it can. So junctional epithelium is now going to have ridges into the connective tissue microscopically. And the sulcus epithelium, sulcular epithelium of the pocket thickens. So that sulcus is going to have more cells in it. So it's going to thicken, and that deposit's going to get stuck in there, and it's just going to pry away. But this is still going to be a lot of cells here, and then it's going to get a little loopy in the junctional epithelium. So microscopically, in the sulcus of periodontitis, we're going to have junctional epithelium creates ridges into the connective tissue. It just wants to connect to anything, okay? Anything it can. And then the sulcular epithelium of the pocket thickens. More cells, okay? There's going to be more. It's no longer a nice, smooth, little, tiny, little cell layer. It's going to thicken. It's trying to keep itself. It's your body working itself, Okay, did we get that? Okay. Let's see, there's a star here too. Even in severe horizontal bone loss. There is one set of gingival fibers that remain present. So even though all of the supragingival fibers are destroyed in all that periodontitis and gingivitis, in severe horizontal bone loss, you're still going to have one of those gingival fibers remain present. And that is your transeptal fibers. Star, so transeptal. So from septum to septum, I'm thinking like from bone to bone, tooth, you got bone here, tooth in the middle is my head. So they want to try and stay attached. You want to try and keep them together some kind of way. Those transeptal over the septums that go across, not the circles, but they go straight across. In the gingiva, not down in the periodontal ligaments, in the gingiva, they're just trying to hold it together, okay? They probably go like across the tooth and stuff, and the gingiva like across the tooth. They're going to try and stay there to hold them together. Your body's still trying to maintain your teeth together because they're so important. Transeptal fibers are still there, even in horizontal bone loss. So, star on inflammation. We know what inflammation is. Inflammation ends in itis. Anything that's itis we know is inflammation. And it's the body's normal reaction to injury or invasion by disease producing organisms. So the body's normal reaction to injury or the body's normal reaction to injury or invasion by disease producing organisms, okay? Inflammatory process occurs in periodontal disease, resulting in destruction of all tissues of the periodontium, including alveolar bone. So enough inflammation over time, if it progresses into periodontitis, we know can resorb the bone. We got that. We know that. It destroys everything over time if it goes into periodontitis. Blah, blah, blah. Okay. Where is the JE in gingivitis? We've actually already discussed this. We know that it is at its normal level. In gingivitis, that junctional epithelium is still going to be, excuse me, at the CEJ. Excuse me. It's not going to recede. It doesn't need to go down. The probing depths are going to be about 4 millimeters, but it's not horrible, okay? So it's going to be at its normal level. Bone in periodontitis. There's a star here. We know this. Periodontitis, there's bone destruction, and it may be severe, progressive bone loss, and may eventually lead to tooth loss. We know that. Periodontitis, bone loss. Could be tooth loss. We know that. If it resorbs enough, you're not going to have anything holding your teeth in there. Okay, I've got a cough again. It'll come out in just a minute. Hopefully not. Gingival pockets of gingivitis. We kind of went over this already as well. So this is cool. This is very repetitive. There's a star here. So, deepening of the sulcus due to inflammation. Well, we know that. It's going to give us 4 millimeters instead of 3 millimeters. That junctional epithelium is still where it's supposed to be, but because it's inflamed, it grows. So it makes the pocket from the gingival margin down to the JE more, There is no apical migration of the junctional epithelium. There's no reason for it to recede. It's just inflammation of the gingiva. So it grows up, and that gives us our 4 millimeter reading. Its coronal portion of the JE detaches from the tooth, resulting in slight increase of probing depth. So the junctional epithelium, the top of it slightly increases, giving us that deeper reading from the inflammation. But the JE still remains. This says coronal to the CEJ, but it's at the CEJ. It's either, oh God, I guess we got to know that. I'm going to go back through the PowerPoints and text y'all. But JE remains coronal to the CEJ. That's what it says about gingivitis. Gingival pockets. Okay, so the JE is still going to be there, but the top of it kind of goes up a little bit. So it detaches from the tooth, resulting in slight increase in probing depth. Swelling of gingival tissue contributes to increased probing depth. We said that. So, okay. Pseudopockets, star, false pockets. False pocket, no destruction of the PDL fibers or alveolar bone. We know it's a false pocket. We know it's really 3 millimeters, but because of the inflammation, it's going to give us 4 millimeters. Pseudo pocket, it's a false pocket. Maybe that's what that means. Okay, so healthy sulcus versus gingival pockets. We know in health, the JE attaches along the entire length of the to the enamel of the tooth. In a gingival pocket, the coronal portion of the JE detaches and the gingiva swells. We know this, okay? We know that. There was no star there, but we already went through that. So we need to know it. There is a star on another one. So in health, the JE attaches along the entire length to the enamel of the tooth. In gingivitis, it's going to swell a little bit, and the top, the coronal, the JE, detaches just a little bit and gives us a little bigger reading. Okay. What happens to the bone when the junctional epithelium is destroyed? Bone resorption. We know that. If the junctional if the junctional epithelium is destroyed, remember that biological width, if it's destroyed and it's coming down some, so's the bone. It's going to stay 2 millimeters, 1 millimeter in fibers and 1 millimeter of junctional epithelium maybe. Okay, so the bone crest and JE increases to 2 millimeters. I guess 2 millimeters a piece. I don't know about that. There is a question mark there. I don't know. There's no star here, so we're good. But bone resorption and biological width changes just a little bit, as in it just moves down. Okay, it still wants to stay. It's the distance between kind of still stays the same. It just moves down. Okay, but bone resorption. Periodontal pockets. There's a star here. We just went through that. We know periodontal pockets has apical migration of the junctional epithelium. Okay, that's the main takeaway from this. Apical migration of the junctional epithelium in periodontal pockets. Movement of cells from the junctional epithelium from the normal position to a position apical to the CEJ. Destruction of periodontal ligament fibers. We know this. Anytime that happens, you're going to destroy some of them fibers that were there holding it up. The crestal fibers, where are they now? If there's no crest of the bone, is there crestal fibers? No. Okay. Whew, we're almost halfway there, guys. Whew. Okay, chapter 3 is a lot, but we got this. What are the 2 types of periodontal pockets? Okay. Periodontal pockets, well, we know that's apical migration of the junctional epithelium because we've said it out loud. We know this. Now, there's 2 types of them, and there's a star here. So there is. So you have suprabony and infrabony, okay? So 2 type of periodontal pockets, infrabony and suprabony. A suprabony pocket, there's a star, we got to know this, occurs when there is horizontal bone loss. Okay, so horizontal bone loss, okay, remember from CEJ to CEJ, the next tooth, even if it's like this and it's going down, it's not vertical, it's from CEJ to CEJ, that's how the bone goes, the morphology. Okay, so horizontal bone loss is suprabony. The junctional epithelium located coronal to the crest of the alveolar bone. So basically, the JE, the junctional epithelium, is above the crest of the bone. Suprabony, above the bone. Junctional epithelium is above the bone. Okay? So even though there's bone loss, it's still above the bone. Okay? Horizontal bone loss, it's still above the bone. Okay? It's coming here, but your bone's right here, still above the bone. Okay? Suprabony. Infrabony pocket, there's a star. What do we think this is? Infrabony is basically the opposite. So it's below the bone, and that happens when there is vertical bone loss, right? So vertical bone loss, you have infrabony, okay? Because it's that cleft, it goes straight down, and your bone is resorbing, but it's here, and you have vertical bone loss, okay? Vertical, so the bone's here, so it goes below. The junctional epithelium's way down here. It's really sad. So The base of the pocket is located within the cratered out area of the bone alongside the root surface. So you still have bone here and it swoops down and back up, but the junctional epithelium is way down here and your bone's up here. Okay. Really sad, but since your junctional epithelium is way down here, infrabony. Okay. Now, here's where it gets a little crazy. We got this though, okay? We got this. Horizontal pattern of bone loss. Okay, so we're talking about the bone loss. Horizontal, we know is from the CEJ to CEJ of the next tooth, okay? And it's got to equal it no matter how the angle is. If your CEJs are going like this and it's going straight down, it's got to be parallel with your CEJs, horizontal bone loss. No matter which way it's directed, as long as it's CEJ to CEJ and parallel with that, it's horizontal, okay? So the pattern of horizontal bone loss, there's a star here, is the most common pattern of bone loss, okay? So margin of alveolar crest remains mostly. We know that because it's super bony, right? Yep, horizontal super bony, so we know that crest is still there. So perpendicular to the long axis of the tooth. Perpendicular to the long axis of the tooth results in practically even overall reduction in the bone height. Okay, we know that, yeah. So the most common pattern of bone loss is horizontal bone loss, where the crest is still there because we know it's super bony. It's perpendicular to the long axis of the tooth, so it's going to stay this way, right? It's perpendicular. We've got it going this way, and your tooth is going this way, so perpendicular. And it results in a practically overall even reduction in the bone height. So it's all going to be even. Okay, that was easy. We know that. The pathway of horizontal bone loss. Here we go. Here's a star. We know we're going to need this. He's going to test on this. The pathway. So let's think about this. So if we have, this is my bone, this is my tooth. So we have the bone is here. Apical, this line here will be our junctional epithelium. We know it's super bony. So if it's an even, right, even bone loss, bacteria are going to invade what? They're going to invade the connective tissue, and then they're going to connective tissue? I guess that's in the gingiva. I don't know how to do this one. Okay, just know that bacteria invade connective tissue and then through the alveolar bone, so they're eating it straight across, and then into the periodontal ligament is their path of least resistance, okay? Let's do this again. Okay, we got this. So in horizontal bone loss, we know everything is about even. So when they come across the bone, they're going to cut right straight across the bone, right? Because it's horizontal. Everything's got to be even. So they're going to go through connective tissue, eat across the bone, and then they're going to get into the periodontal ligaments, okay? Because here's the bone and periodontal ligaments are there. Even though the crest is gone a little bit, there's still some fibers. So they're going to come down the connective tissue, across the bone, horizontal, and into the PDL. Okay, and that's how they reach the tooth and the sulcus. Okay, not too bad. All right, horizontal bone loss pocket. Okay, there's a star here. Okay. We know it's a super bony pocket because why? It's above the bone, right? It's horizontal. It's just cutting straight across through the connective tissue, straight across the bone into the PDL. We know it's super bony because that junctional epithelium is above the bone. The base of the pocket is coronal to the crest of the bone, or crest of the bone is apical to the base of the pocket. This is the base of the pocket. We know that. Okay, boom. That was just another star in a different worded way of saying what we already know. We got it. Horizontal bone loss. Straight across, CEJ to CEJ, no matter what. They're going to go through connective tissue across the bone to make it even and into the PDL. Okay? Super bony because it's above the bone. We got it. Okay. Vertical pattern of bone loss. There's a star, of course. He's going to ask about it. So let's do the vertical pattern. Okay? So it's least common. You're not really going to see this unless there's something really going on that's making it cleft straight down, okay? It's an uneven reduction in bone height. Well, yeah, I'd say so. If it's not horizontal, it's not straight across. It's a uneven reduction. It is uneven. Here's a CEJ and CEJ, but it's going bloom way down there. And there's your junctional epithelium. And here's your bone, okay? It's infrabony. It's rapid progression of bone loss next to the root surface. So rapid progression of bone loss next to the root surface leaves a trench-like area of missing bone alongside the root, okay? That makes sense, okay? So it's less common. This doesn't happen often unless something's really going on in that one spot, So it's an uneven reduction in bone height. Uneven, we got it. It's not horizontal. It's rapid progression of bone loss next to the root surface. Boom. Of course it's going to be next to the root surface. It's a trench. Okay. Pathway in vertical bone loss. So the pathway. Okay, let's do it. We could do horizontal, so let's do the pathway of vertical. Okay, there's a star here. So the bacteria are going to invade the gingiva. Okay, the gingiva. So they're going to invade the gingiva, the periodontal ligament space, and then they're going to cut into the bone. So it's basically opposite. We have connective tissue through the bone into the PDL for the horizontal to make it straight across. This one's going to go down in the gingiva. So it's going to mess up the gingiva into the sulcus. So gingiva, periodontal ligament space, and then into the bone. Okay, so it makes a weird vertical bone loss kind of thing. Vroom, okay? I know that's weird, but we'll just remember that. So it goes through the gingiva into the sulcus. So it's through the gingiva into the PDL and into the bone, okay? Occurs when the crestal periodontal ligament fibers are weakened and no longer act as an effective barrier to inflammation. That makes sense because we know crestal fibers are at the top of the bone, right? So if they're going through the gingiva, here's our junctional epithelium, this is our sulcus right here, our little free gingiva, our tooth, they're going to go into the gingiva, into the periodontal space, and into the bone, okay? Makes sense. Those crestal fibers aren't really strong. Okay. Infrabony pockets. There's a star here. We know about infrabony pockets. Vertical bone loss, infrabony, it goes down below the bone. Base of the pocket is apical to the crest of the bone, okay? Or the crest of the bone is coronal to the base of the pocket. Don't get confused with those, okay? Just know the base of the pocket is below the crest. So if you ask it opposite, you know the crest is above the junctional epithelium. You want to know where that attachment is. Is the attachment below the bone? Is the bone above the attachment? Okay, don't get confused with that. Okay, we want to know where that junctional epithelium is. If he's asking where the bone is, it's above the attachment in vertical, okay? If he's asking where the attachment is, it's below the bone in vertical. Okay, I know that can get confusing, so read the words carefully. Let's keep going. What are the 3 pocket types? 3 pocket types? Okay, we know this, okay? So we know there's 2 periodontal pockets, right? We know there's suprabony and infrabony. Well, we know in gingivitis, if it's 4 millimeters, that's also a pocket, right? So, okay, let's not get tripped up on this. So the 3 pockets, we have a gingival pocket, which is no bone loss, but remember it kind of grew up a little bit. That junctional epithelium, the coronal portion of it detached a little bit. So now we've got a bigger reading. Still a pocket because it's more than 3 millimeters. It's disease. So gingival pocket, then we have 2 periodontal pockets, infrabony and suprabony. Suprabony, above the bone, vertical bone loss. Infrabony, below the bone, vertical bone loss. Okay, pretty easy. Here we go. Okay, you keep it up. If you need a pause, take a break, go for it. But I got to keep going because I don't have a pause. But we're getting through there. We're almost done. Infrabony defects. There's a star here. So whenever we have infrabony, we know that there's vertical bone loss and there's a space there, right? Because all those periodontal ligaments are destroyed. The Gingiva is destroyed, the bones part destroyed, so we have the space, okay? The bony defect in infrabony, this is only for infrabony. So infrabony, if we're having these defects, we know it has to do with the infrabony space because there's vertical bone loss. There's no bone keeping it up right there. So, and it's along the root surface. So the root is exposed and there's like a little, this is where the walls come in, okay? We're going to get through this. So bony defects are called osseous defects. Osseous is just another fancy name for like bone defects, okay? So bony defects are called osseous defects, okay? Osteoblasts, osseous defects, okay? They result when bone resorption occurs in an uneven, oblique direction, generally affects only one tooth. This is why vertical bone loss is so uncommon, is because it typically only affects one area because something's going on in that area, and we know it goes straight down and it's in like a vertical angle, or excuse me, an oblique angle. We know it's vertical, straight down, and we know it's oblique. We know there's a space there now because it's a defect down on the root, right? Okay, so it's classified based on the number of remaining osseous walls. So the remaining bony walls. Let's say that again. It's classified, your infrabony defects, your osseous defects, are classified by the number of remaining walls, okay? So you have a 1 wall, 2 wall, 3 wall, and an osseous crater. Okay, so let's get through this. How are infrabony defects classified? Based on the remaining osseous walls, bone walls, okay? The more walls remaining, the better the prognosis for repair. So 3 walls are best for the repair. If we have 3 walls to work with and only 1 wall's missing, we can build that up. We could pack some bone in there and let it heal. We could try, okay? So just know that the defects, the best way to repair them is if they have 3 remaining walls, like the house, right? If we have 3 walls, 1 wall missing, at least the roof can balance on the other 3, right? Okay, so here we go. You ready? 1 wall, infrabony defects. Okay, we're going to start with the 1 wall. This means that there's only 1 wall that's remaining. There's only 1 wall. Okay, so in 1 wall, we're going to start here because you'll see how it builds on, okay? So in 1 wall, that means 1 wall is remaining, okay? And it's the distal bone only remaining. The distal, okay? So in 1 wall, it's the distal bone remaining. How can we remember this? So, the distance between us. There's so much space between us. We're never going to fill in this space. Okay, we're never going to fill in this space. It's terrible. There's 1 wall left. We're never going to be able to fill in this space. There's so much distance between us. Oh my God, is that a bug? Ew, ew, there's a fly in here. Okay, got it. Okay, I got it. Oh my gosh, ew, what's wrong with add-on houses? Okay, anyway, so, here we go. So, the distance between us, okay? There's so much distance between us. There's only 1 wall remaining. It's the distal wall. There's so much distance between us. We'll never be able to fill in all this space, okay? Distal wall remaining. There is no bone on the facial or lingual. I'm the mesial root, I guess. So the root is exposed, right? We know that because in vertical bone loss, it's on the side of the root. So we know the root's exposed and it's on a little oblique angle, right? So this must be the distal wall. The distance between us, there's no facial wall and there's no lingual wall, okay? So with 1 wall, the distance between us will never be able to fill in all of this space, okay? So the distal bone only is present. 1 wall, bad prognosis. Root is exposed, no bone on the facial or lingual, only the distal, okay? Now see how we're filling this in. You'll see how this works. 2 wall. So a 2 wall infrabony defect. And there's stars on all of these. 2 walls. So we know we're always going to have that distal wall no matter what. Okay, we're going to build onto the distal. We're going to get better. We're going to end up with our 3 walls, which is better for prognosis. Okay, so we're going to build up to the great prognosis. Well, the best option. So we know that distal wall is always going to be there because in 1 wall, the distance between us, that distal wall will be there. In 2 wall, we're going to go distal and lingual is present. Okay, distal and lingual. When I think of lingual, I think of the tongue, and it's almost like we're going to sing to somebody to come back, okay? The distance between us, we're going to start singing because we miss them. We want some more. We need to fill in that void, that space. We need to fill it in, so we're going to sing them a song to bring them in, lullabies, whatever we could do, we're going to sing them with our lingual, with our tongue. We're going to sing. We want them back. So in 2 walls, we have our distal wall and our lingual wall, okay? We're singing. We're trying to get to fill in that space. Come on over. Everybody come home. I want all my children home for Thanksgiving. We got to fill in this space. There's so much distance between us. Well, I'm going to sing to you with my lingual tongue, okay? So distal and lingual bone remains. Still no bone on facial, okay? So I haven't seen everybody's face yet, okay? So the distance between us, 1 wall. 2 wall, distance, lingual, because we're going to sing to them all to come back, okay? But still no facial. Not everybody's faces are present yet for Thanksgiving. And the root is still exposed. Well, yeah, the root is going to be exposed in all of these because we know in vertical bone loss, that's what it is, okay? So, 3 wall infrabony defects. We know because infrabony is vertical, that root is going to be exposed, right? We know we always have our distance. Our distal is the 1 wall, our 2 wall. We're going to sing to them to get them back. So distance between us, sing to them with your lingual tongue. And now we've got all of their faces. Now we've got our 3 walls. We're happy. We're filling in this space. We can do it. We can fill in this space. We can do it. We can mend all of our differences. We're all together. Faces, linguals, distance, or distal, So everything remains, but the root is still exposed. So there's still just that little space, but we have our facial, lingual, and distal, okay? This is going good. And then we have our osseous crater. So, osseous crater. It's a crater. It's a bone crater, right? Don't let these words fool you. So it's a bone crater. It affects 2 adjacent teeth. Okay, so you've got 2 teeth, and it forms a bowl-shaped depression on the interdental alveolar bone. So all this is an osseous crater, so you don't have to worry about all these walls missing or anything. It's literally just probably that crest goes down and resorbs, so you've got this dip. It's like a bowl. It's a bone crater. So you have, oh yeah, the bone. The bone resorbs a little bit and makes it goes in the middle of the crest, boom, and you got the edges still up, but it's like a bowl. So you've got a bowl. It's an osseous crater, a bone crater. So it forms a bowl-shaped depression on the interdental alveolar bone. Proximal root surfaces are exposed. So in between, so it goes down since it's receding a little bit, since it's going away a little bit, so are the gums. So you're going to see both of the proximal root surfaces, okay? So your junctional epithelial, okay? And it's going to be actually down here because you know why? It's still vertical bone loss. It's still an infrabony defect, right? So you've got this, but it goes whoop and then down again, I guess. I don't really know about that, but just know it affects 2 adjacent teeth because you need the crater to attach to something, kind of like the coal, So an osseous crater is just a bone crater. It's a coal of the bone. It's a concavity, a concave thing. So it forms a bowl-shaped depression on the interdental alveolar bone. Proximal root surfaces are exposed because it's vertical, right? And then it forms a plaque trap. Well, yeah, we know that with coal too, and it's difficult to clean. Well, yeah, it's a little divot. They like to bury down in those caves. So yeah, we got that. Whoo, we made it. We made it. We made it through those walls, okay? The distance between us, you're going to sing to them, so your lingual's there. Now we got our 2 walls. Third is everybody's faces are there. Boom. Best prognosis. Got it. Okay. Furcation involvement. There's a star here. We know what a furcation is. It's between the roots, right, of multi-rooted teeth. So furcation involvement occurs on a multi-rooted tooth when the periodontal infection invades the area between and around the roots. Okay, so we know periodontal infections resorb the bone. If you resorb it enough on a 2 root or 3 root, we know we're going to start seeing that furcation area. So that's furcation involvement. The furcation area may be hidden by gingival tissue or clinically visible. We know that because there's different furcation classifications. Okay, here we go. We're on the downfall now. We got this. Like, this is going good. Okay, it's all easy from here. Attachment loss. There's a star here. We know about attachment loss, okay? The destruction of fibers and the bone, okay? So attachment is by fibers, you know, PDL is still fibers, even though the ligaments are still fibers. So the destruction of fibers and alveolar bone. Loss of attachment may vary from surface to surface of the tooth. Base of pocket may exhibit irregular patterns of tissue destruction. Yeah, we know, because it could be vertical, could be horizontal, and it could be any surface, any place, anywhere, anytime. We got that, okay? What is a disease site? There's a star. An area of tissue destruction that may involve one surface of a tooth, several surfaces, all four surfaces of a tooth. All right, let's read that again. There's a star here. What is a disease site? So it's an area of tissue destruction. It can involve one surface, it can involve multiple surfaces, or all the surfaces, okay? That's all that is. An active disease site means that it shows continued apical migration of the JE over time. You like that, right? So we know in disease, if it's a periodontal disease, if it's, periodontitis, if there's periodontally involved, there's bone resorption, and we know that there's apical migration of the junctional epithelium over time. So active disease sites show continued apical migration over time. It is going. Inactive disease site, star. The site is stable, even though they have, reset all, you could see all the furcations. I mean, it's all showing, right? But there's no inflammation. We've got it nice and cleaned up. They'll never get their gingiva back. They'll always be periodontal patients, but it's healthy tissue. And basically, there's no more apical migration. Disease is not still chewing at the bones and stuff. It's stopped. So with the attachment level of the JE remains the same level for a period of time, majority of periodontal pockets. So typically periodontal pockets are not always, but most likely they're going to stop once you get all that stimulant out, all the bacteria out, clean it up. Even though it's already recessed and gone and destroyed, it's going to just stop. It's a inactive disease site. When should periodontal disease activity be assessed with a periodontal probe? At regular intervals. You always want to do that. There's no star there though. What does a periodontal pocket indicate? There's a star. It's an indicator to past destruction of perio disease. So a periodontal pocket is going to indicate that there was some kind of past destruction of periodontal disease, whether it's now or yesterday. Well, I guess now would be active, but okay, so what does a periodontal pocket indicate? If you had a periodontal pocket, I know that you have had in the past destruction of perio disease, okay? Tissue graft, no star. It's just for clinical attachment. It's a very short clinical attachment because of recession. All right, what is disease progression? Star. Disease gets worse. That's easy. Pattern of disease progression varies from, there's a star, one individual to another, one site to another in a person's mouth, one type of perio disease to another. It's never the same. The pattern of disease progression varies from every angle you could think of. So from person to person, from a site to another site in somebody's mouth, from a disease to another disease. Almost there. What are the 2 progression theories? Oh boy. Okay. So 2 progression theories. There's the continuous progression theory. So continuous progression. So this is a progression theory that we're talking about. So there used to be in 1980 the continuous progression theory. So they thought, oh, you know what? It's just going to keep going and going and going until it's all gone. But we know that's not the case because you can stop and arrest. You can make it inactive. You could stop that apical migration of the junctional epithelium, right? So now our current view, the second one, is intermittent theory of disease progression. Intermittent. If you know what that means, it's kind of like go, stop, go, stop, go, stop, at least in my mind, right? So the 2 progression theories back in the day, continuous progression theory, they thought it was just going to keep going, going, going until it's all gone. Okay, once you get it, that's it. It's done. Your teeth will fall out. Not the case. We know now that there's an intermittent theory of disease progression, which is the current view. So continuous progression, we know period disease progresses throughout the mouth at a slow, constant rate, goes, gone, no star. We don't have to know about the 1980s, what they did there. We know continuous progression theory. We know that doesn't exist. We know it's not going to keep going, and then it's all out. But we do need to know the intermittent theory of disease progression, which, like I said, is kind of like go, stop, go, stop. So it's the current view, and it's periods of disease activity and inactivity. Excuse me. Okay, so sporadic progression, so different rates throughout the mouth. So it'll go, stop, go, stop. Intermittent, okay? Go, stop, go, stop. We know this. It'll go and then it'll stop. And it might start again if you stimulate, but we can stop it again, okay? Go, stop, go, stop. Untreated gingivitis does not always turn into periodontitis. That's why that last one was not good. Okay, we're almost there. Less than, I'm not even going to say it. Okay. Epidemiology. Star, the study of health and disease within the total population, not an individual. What are we looking at here? Epidemiology, we know what this is. Epidemiology, the study of health and disease with the total population, not just the individual. We strive to identify risk factors associated with disease. Identifying risk factors can lead to theories of cause and a disease and treatment standard. Okay, so all this is saying epidemiology, we know this. It's the study of a population instead of just one person. We look at risk factors to see what those may do in that population. Is everyone smoking? Is that what's contributing to it? What are these people doing, you know? Okay. Risk factors. There's a star here. I wish there wasn't, but it's okay. Okay. So risk factors. Yes, we will get to know these very well. So let's start now. Okay. Risk factors. Increase an individual's susceptibility to a disease. We know this. Examples. Hereditary. Gender. Physical environment, systemic factors, diabetes, social economic factors, personal behavior, as in, are they smoking? Are they incompetent. I meant non-compliant with their brushing methods, okay? And stuff like that. So look over that, you know. Incidence, there's a star, rate of new cases of people with a disease within a specific period of time. We know this. We just did this. Incidence, new cases. Prevalence, number of people having a disease, both old and new, that are identified in a specific population at a given point. So number of people, past cases, new cases, or number of people, prevalent, you know. Oh, prevalence. Prevalent is what we, like, it's like a mouthwash or something we give to people. Okay, prevalence, number of people having a disease. Incidence, number of new cases. How is prevalence, I keep saying prevalent. How is prevalence of periodontal disease in the adult population determined? By performing clinical examinations, yada yada. We know this. You got to do clinical examinations and stuff like that. You know, if they're affected by new cases, old cases, that's just silly. By performing clinical examinations on cross sections of group using indices. So we know that. Prevalence, periodontal disease, use indices. We know that. We're going to indicate how everyone's getting this stuff. Epidemiologists of periodontal disease. We have 3 more. Woo! So epidemiologists of periodontal disease. There's a star. Study of periodontal disease to determine its occurrence in the population to identify risk factors for periodontal disease. So epidemiologists of periodontal disease basically take the population and they identify the risk factors for the periodontal disease. Okay. Why is it easier to evaluate a population for caries than it is for periodontal disease? There's a star here. Because measuring caries is more objective. So caries, you only have so many surfaces. You can clearly see that. Development and disease progression is well known in caries. We know where it's going to go. My phone's going to die. Development and disease involves only one tooth structure. Evaluation of periodontal disease is less specific. Yeah, because it could be anything. Periodontal disease could be so many fluctuations in it. 2 more. Why is it difficult to measure periodontal disease? We just answered that. Because it involves hard and soft tissues. There's multiple variables to consider. Tissue changes, bone loss, degree of probing depths, and bleeding, right? Last one. Thank the good Lord. What does research show? Star. Most individuals that have periodontal disease do not know they have periodontal disease. Woo! We know that. Most people that have it don't know they have it. Whoop, whoop. We're done with chapter 3. That was the biggest one, and they all were like stars, and we got that, though. Okay, on to the next. Woo! Test tomorrow. Let's do it.